Good afternoon. I'm excited to be here and talk a little about, share some of my experiences pertaining to treating lipedema from a surgical point of view. In my clinic, I like to emphasize the importance of comprehensive care. And I think as a good foundation, self-care is important, but then we add as layers on a proverbial cake professional care with allied health care as primary care, and then for those that need or desire, surgical care. This is summarized a little bit in this slide that talks about different aspects of self-care as well as professional care that can be facilitated by primary care here in the United States, as well as with the allied health professionals. I'd like to share some experiences that I've had and some insights that I've had providing surgical care. In my mind, there's two different types. There's a minimally invasive technique, therapeutic lipedema reduction surgery, as well as a more invasive and open technique. I'm going to talk a little bit about my experiences from what we call Taylor's therapeutic lipedema reduction surgery. I try very hard to customize a treatment plan for each of my patients. While I have standard tools at my disposal, I want to do what's best for the patient. And the goals are to stop the lipedema from progressing, to reduce or eliminate pain, to improve mobility, to minimize the risk of secondary lymphedema after the procedure, to restore joint alignment, and to improve gait. I like this picture from a paper almost 15 years ago that illustrates some of the challenges that lipedema patients can experience in altered gait. In unaffected individuals, the body is designed for the hip, the knee, and the ankle joints to be in complete vertical alignment. That's illustrated here by the red lines. We can see in this particular patient there's significant malalignment because of the disease, and we can only imagine how this creates both short-term and long-term consequences for the patient. In my clinic, as I develop a treatment plan, I start to work and plan out the legs. In some cases, across the top, I will treat the patient in 2 stages, 2 procedures to completely treat the legs. In some patients who have more advanced stages of the disease or additional tissue, I may need to break that process into 3 surgeries. What I found was that in this process, the way that I've set it up, is that it allows me to look between the medial aspect and the lateral aspect of the legs. So here in green, in a patient with 2 stages, the lower legs in stage 1 are treated the medial aspect, and then in the second stage, it's the lateral aspect. This provided, in retrospect, kind of a unique situation, an opportunity to analyze some physiology associated with lipedema. And so here, basically what's happening is in one surgery, I'm treating the medial half of the legs, and then on the other surgery, I'm treating the lateral half. And so I wondered, is there a difference? So my data here is from all of my patients. These procedures were performed in order. They're usually a couple of months apart, done by the same person, the same assistant, the same equipment. I use power-assisted liposuction, the same technique, and all the same measurements. And so I felt like we were uniquely positioned to analyze these numbers. And so what I found was, interestingly, we have asymmetrical removal of fatty tissue. And so here, as you can see down below, I'm going to go back. Typically, we look at the lower legs and say, well, there's fat circumferentially around the tibia, and the fibula is off to the side. And so we would think that the same amount of tissue would be on the medial aspect and the lateral aspect. And what we found was that was not the case, that there was more fatty tissue removed that could be removed from the medial aspect. So, for example, when I took all of these numbers and added them together, I found that there was 83% more fatty tissue in the medial side of the leg than the lateral side of the leg. So for example, if I remove 300 milliliters of fatty tissue from the outside of the leg, that would correlate to 549 milliliters on the inside, a significantly amount that was different. Interestingly, if we compared right leg versus left leg, there was no difference. So that's good. Things are running well. We're operating symmetrically from the body as a whole, but the halves of the legs seem to be different. And so I asked the question thinking, well, if there's more fatty tissue on the inside of the leg, is it just one particular population of patients? And so I did a subset analysis, and I said, well, let's group people by stages. So interestingly, I found that even in stage 1, there's 132% more fatty tissue on the inside, the medial aspect of the leg, than the lateral leg. That would correspond here as an example, 300 milliliters would remove 696. So 132%, that's over twice the amount of tissue on one side of the leg versus the other. So then I thought, okay, well, what happens if we take patients that have more advanced stages? Well, stage 2, it becomes more pronounced. Now it's almost 2.5 times the fatty tissue on the inside of the leg than the outside of the leg. So that would correlate to 747 compared to 300 milliliters on the outside. So then I went to stage 3. Well, interestingly, not as much. So still 58%, that's another 50% in volume. With the 300 mils as our example, I would get 474 that would come afterward, that would come from the medial compartment. So if I put this in a graph, here's how this portrays. If we look at the subgroups, symmetry, in other words, between the medial side of the leg and the lateral side of the leg, symmetry would represent 0 in this graph. In other words, there's no difference. They're the same. So you can see again in stage 1, there's a significant 130% difference in the medial aspect versus the lateral aspect. And again, it persists with stage 2. Interestingly, it wasn't as high with stage 3, but it was still there. There's this asymmetry that's going on. So why is that the case? I don't know, I've ruminated over it for a while. Is it the way that the patients load their body, meaning the way that they walk? Is that having some long-term effect? Is it positioning, the way they sit in a chair or something? Is it effects of clothing that they choose to wear? Or maybe the changes in mobility? It's interesting because the difference seems to be more pronounced in the earlier stages than in the later stages. I'm not quite sure why. So then I thought, well, what's the difference between the medial aspect of the leg and the lateral aspect of the leg? Because maybe that could shed some light. We'd think that the leg is symmetric all the way down, but it's not. For example, if you reach down to your lower leg and you feel the outside of your lower leg, there's 2 bones down there, where there's only 1 bone in the upper leg and the thigh. So already there's some subtle differences. But some of the anatomical differences that we can see are illustrated by this one, the vascular compartment. You'd think that the vascular compartment would run all the way down the middle of the leg, all the way down to your toes. It does not. It follows the medial compartment. And for this example, I've got the saphenous vein illustrated from the ankle all the way to the groin. And so that made me think, well, so if the vasculature is shifted to one side, could that be playing a role? I remember recently in the last year or two, Dr. Herbst had shared a hypothesis about saphenous compartment syndrome as a possible etiology for lipedema. And here we have asymmetrical production of fatty tissue, and it's biased toward the medial side. Is there a correlation there? I'm not sure. Another thought is that follows the vascular system is the lymphatics. We've heard some great presentations about this and the importance of lymphatics, and we know that that's the case. It's interesting because initial studies show that there's great lymphatic flow, but again, the lymphatics are more heavily biased on the medial compartment. Is that playing a role in the growth of lipedema? Here's an example of a patient who has a similar situation. She had a mastectomy from cancer, and you can see in the left arm it's significantly swollen. Now, she has lymphedema, but if you go up and examine her, she has lipohypertrophy, which is growth of adipose tissue, which we know happens from lymphedema. And so, is there a correlation there because we have more fatty tissue in the medial compartment? I don't know. What about the genetics? Are there different genes being expressed on the medial side than the lateral side? I don't know. We've got some researchers here. Maybe we need to get some tissue biobank from different sides to try and answer that question. So I think that this is interesting because I think it creates a new avenue for possible causes about lipedema because we see a difference that we didn't quite expect. In addition, for me, it helps me plan as a surgeon so that I can optimize my care for my patients, and I think that that could be helpful in the future. Limitations for this observation that I'm sharing with you. Number one, I'm making the assumption that people that don't have lipedema, that their legs are symmetric. Well, if I reach down to my lower leg and I push on the subcutaneous space on the outside and I push on the subcutaneous space on the inside, feels symmetric to me. There's no real good way to do that study. I've actually never performed liposuction on a non-lipedema patient in the lower leg. Just doesn't happen. Sometimes we'll do focal areas, but I don't do the entire lower leg. So there's no way for me to really compare to say, well, is that a legitimate finding? But I think it's hard to argue with the numbers. The numbers I've shared with you today are preliminary. They are the result of just over 20 of my patients. But I'm going to go back 5-6 years and start to gather this data because I think the number is there. Another limit is that this is retrospective, and so there's a little bit of bias there. And there's just one site, just my site and one technique. So maybe it's different with other surgeons. So I think future directions, if people are interested, well, we need more power to the study. So that's why I'm looking to increase this to 6 years of work and pull all of this data out. But I think the numbers are going to be there. Can it be reproduced in other clinics? Now, the challenge is not all the surgeons do the same technique. Some will perform treatment all the way around the leg, and so there's no real good way for them to figure out if there's a difference. Does this hold true with other techniques, such as water-assisted liposuction? I would think so, because the tissue is there. And then another thought is, will this observation remain true in the upper leg? Fortunately, the way I document in my clinic, I have those numbers in there also. I think that would be helpful because if there is also more fatty tissue in the upper leg, then it suggests that it's the entire length of the leg, and again, validates this finding to say there's something different going on in the medial aspect of the leg than the lateral aspect, and maybe that supports the saphenous compartment syndrome hypothesis. I don't know, but I think there's lots more out there and more to learn, and hopefully observations like this can not only guide clinical care for optimal results, but also help us find a solution and an etiology for this condition. Thank you.